All right, welcome everyone. Yeah, it's just a reminder there. If anyone's got any questions, remember there is a Q&A box, so just please put it there. So we're going to start. I can see from the registrations that some of you may have been here in the previous lecture last week, but other ones not. So I'm just going to very quickly introduce myself. So my name is Manuel, and I'm one of the radiologists working at VetCT. One of my areas of work of interest is image quality, and this is what we are going to be talking about. It's a topic I'm quite passionate about. I think it's critical that us radiologists can work with good images for very obvious reasons, but I think ultimately is for the benefit of the patient is crucial that we do it, and particularly when it comes to something like CT, which generally will take a significant chunk of the money available to work up or treat a case. I think it's very important that the images are optimized as much as possible, really, even more than with other modalities. So what we are going to cover, I will start with a very quick overview of the CT imaging process, the different stages, why these are different, and what's special about each of those. Because generally we see this all as a one thing, similar to what we do in radiographs. What with CT, there are quite a few different steps. We will look at the basic concepts of image quality, use some of them, the more relevant ones, which are spatial and contrast resolution, and also discuss the notion of noise, which ties up with both of the other concepts. We are going to discuss a couple of things regarding image processing. We're going to focus on the filters particularly. We'll mention briefly the field of view, and this is not a talk that normally we're going to be covering how, what's the process or the algorithm, the paradigm of how we review images. But we need to discuss a little bit about windowing because I think there's still a lot of people that are confused about what a window is, what a filter is, how these are completely different but interlinked principles. So we will explain that, a bit of very basic, how to plan your protocols. And then I will give you a bit of a paradigm and how to assess image quality in a simple way. So when you open a CT scan, that you very quickly can look at the images yourself and decide if the quality is sufficient. So as I did the other day, I wanted to make a small remark here. We are going to be talking about what we generally describe as conventional or multi-slice CT. If you have any other form of CT, cone beam, flat panel, there will be differences. Everything we're going to say will not apply. In fact, most of it will not, particularly when it comes to soft tissue resolution and things like that, where the different technologies are totally apart. Okay, you can still take home this paradigm about image quality assessment if you've got a cone beam and try it and see what the result of that is. We can always discuss that if you have any specific questions. So let me just 1 second because I've got the dog trying to walk in. Sorry for that. So I was going to explain the basic steps of the process of producing CT images, and there are quite a very distinct 3 steps, which sometimes we mix together. But it's important to make the clear remarks that what we are going to be discussing as acquisition is what is done inside the CT room when you have the patient before or while the scanner is running. So when there is radiation being produced. Now, as part of the acquisition also, you will be using the computer that is generally physically attached to that scanner. So it's going to be in the room adjacent to it in some sort of control room. And basically, this is something that it can only happen in your hospital when the patient is there. Okay. Once the patient is gone, once you are no longer using radiation, the acquisition is stopped. But at this point, all we have is what we call raw data. So it's a bunch of ones and zeros, a very vast amount of data. That at this point is not a visible image, not something that you can use to make a diagnosis. So we need to take all of that raw data and process it. And that's what we call processing. And this happens in the same computer that is just attached to your scanner. Okay, it's important you understand that this is the only way to process those images properly is in the computer that is attached to your scanner, and therefore it is in your hospital. However, this can be done anytime while the raw data is still in that computer. And depending on your setup, that can be up to a few months, okay? But generally at least a week. So this step is technically separated in time and potentially in space. It happens in a different location than the acquisition itself. And then with our raw data, the outcome of this processing, we're gonna get the images that we can all look into, which are gonna be in a DICOM format, and they will be reviewed in some kind of viewing workstation. So a computer with DICOM viewing software. And this last step, it can happen obviously anywhere by anyone at any time, provided they have those images. Okay, so the 3 steps, sometimes they kind of overlap. You may do the processing as you do the acquisition, and then you will view the images maybe in the same computer. But technically, these are things that can happen at separate moments in time in different locations. Now, image acquisition is very important to understand that any errors at this stage, they cannot be undone. Okay, if there is a serious mistake with the acquisition itself, the only way to sort it is repeating the scanner. And there are different stages and therefore different points at which things can go wrong. We're not going to look into detail, but preparing the patient or the position is not correct. Those are not things you'll be able to solve. And also at this stage, you will be selecting some parameters that are going to determine, for example, how the table and the X-ray tube moves, the energy of those X-rays, coming out of the tube. And obviously, those are things you cannot change, retrospectively once the scanner is done. So kilovoltage and MAS are the 2 most obvious. Then how fast the tube moves or the table moves, the pitch. There are quite a few things that you have to set up at this stage. And you may not do this manually every single time. You may just select a body area. If your scanner is properly set up, you are good to go. Now, the other one is contrast administration, the timing and the delay for when you start the scanner in relation to the injection and so on. That's another thing that you really want to make sure you can get all right. And yeah, those are basically the ideas. There is another one which is very important, is that sometimes you get too much noise, which we will explain how to assess. That's generally an acquisition error. So reprocessing the data may help reduce the impact of noise, but it will not solve the issue completely. And image processing is different. Now we've got all that data, and we are going to select some parameters. Mostly, the most relevant ones are going to be slice thickness and the interval in between slices, the filters, which we will discuss, the field of view, so the actual area that you want to get, like to process out of all that information, where you want the study to start and end within the area that is scanned, basically. Now, the good thing about this, errors are extremely common. I think a very big percentage of the cases that we get have some sort of processing issues, unfortunately. The good thing is that this can be solved. Provided you still have the raw data in the control room computer, you can go back and, okay, well, we need a smaller field of view with a bone filter of that elbow or of that spine or whatever it is, okay? As far as you can communicate with the person that can run the machine and interpret it, they can talk amongst them, then it's fairly simple to solve the problems. And the last one is image viewing. And this, we are only going to be discussing the first line there, which is window width and window level. So that's a change that we do to the image, to how the image is displayed, but we do not alter the image as such. We're just basically playing with the contrast and brightness. There's lots of other things we do. We interact with images when we report CT a lot, changing the angles, do 3D recons, measuring volumes, areas, distances, zooming into the image, subtraction. There's a lot of manipulation that we do, but that's not really relevant for the conversation today. I think we're going to focus onto the window a bit later. And these are the 3 basic concepts which I think are the most relevant when it comes to assessing image quality. You want to check the spatial resolution, contrast resolution, and image noise, which in a way it ties with contrast resolution, are part of the same evaluation. Okay, a little bit with the spatial, but mostly with contrast. So spatial resolution, we start with the easiest one and with the one that CT does best. This is the ability to see something, 2 small objects that are nearby, and identify them in the image as separate entities so that they don't fuse into one. Spatial resolution is the same for photography or for any other thing. It's not specific for CT. And if we look, for example, at an elbow, you can see things that are extremely small. For example, you can see this hyperattenuating, so white band here, which is subchondral bone, which is submillimetric. You can see really nicely, for example, the joint width, which is quite constant. It's really narrow, but it's really sharply demarcated margins. We can see the trabecular bone. So excellent visualization of the small stuff. The nose is another very good example where you can check this and you are going to see, you should be seeing perfectly all of the turbinates, the meatus as very sharply demarcated air spaces. Same thing for the teeth. And when it's not bone, the other place where you can check this is in the lungs. And in the lungs, it shows this beautifully. So if the CT of the lung is of good quality, you should be able to see that the lung, mostly the only thing that you see is vessels, except in the periphery. So about 1 or 2 millimeters of lung peripherally looks almost like it's empty. And that's normal. What is happening there is that there are vessels, but they are so small that are beyond our ability to resolve them. That's past the spatial resolution of the system. However, you should always be able to see vessels all the way into at least the fourth division, so the fourth branching of the vessels, and almost reaching all the way to the pleural surface. Now, image noise, I suppose when you hear noise, at least I do, I tend to think more of audible stuff, noise in a room, or when you're listening to music with a background noise. But the idea is exactly the same when it comes to images, and it's not specific to CT, it's the same with a photo. So I did this today. I walked into the room, my son's room, and I took a photo of his guitar. On the left is with an almost dark room, so very poor light. On the right one is the lights are on, and there's actually the flash also. Now, like that, the photos look okay. It's quite amazing how the new phones, you can get a photograph in a dark room and still see color. Is quite amazing. But it's when you start to get close to it. So I'm looking to the sticker that is inside the guitar. And if you look, for example, at this area, in this top image where the lighting is poor, you start to see all of this mottled appearance, all of these little dots, this grainy appearance. You can see with good lighting, it's reduced and it's almost completely gone. So we can assess that color much better. It's homogeneous, and all of these little dots are gone. It's exactly the same thing for a CT. We start to get this grainy appearance. The image is not homogeneous or smooth. And basically what is happening for the photograph or for the CT is that we don't have enough data to make a good image. We've got insufficient number of photons. Now, to some extent, we can live with this. We can smooth this out with the filters. That's what filters do. They will smooth this noise out. They will blur it and get rid of it to some extent. But generally, you need a significant amount of data in order to achieve a good image. So the filters will not solve completely the problem. And if you've got a lot of noise, this is going to affect mostly your ability to see soft tissues, which is what we call contrast resolution. And to a lesser extent, it will also affect spatial resolution. Okay, so having the ability to identify noise is very important. So after discussing that, just quick review of what contrast resolution is. And this is the ability of any imaging modality to distinguish between structures that are very similar in whatever it is that modality is measuring. So in the case of CT, we are measuring physical density. So things that are fairly close but different, in density, can we see them as two separate entities? That's what contrast resolution is. Should not be confused with the ability to see the actual contrast that you inject, okay? If you go for ultrasound, but it would be identifying two things as separate, as different things, despite the fact of being very similar in echogenicity. So that is what contrast resolution does. And it's critical for assessing soft tissues. This is something CT is not as good at as other modalities, and this is why this is the part that is difficult and critical to optimize in a CT scan. Basically, the less noise you have, the better your soft tissue resolution, the better your contrast resolution, basically. And these are just a couple of images. This is the same system, this is the same filter, same slice thickness, different patients, but fairly similar in size. But if you look at the image on the left, it looks very granular. It's a lot to like modeling throughout every area that you can see. The one on the right looks smoother, but there's something more than just being smoother. If you look, for example, inside the brain, you can see really clearly the lateral ventricle. Here you still see it, but it starts to get less clear because of the noise. But there are things like, for example, the white matter. You see that darker area inside the brain, you can see it irradiating. So that's the corona radiata, that is the white matter of the brain. And if the image is sufficiently good, we can see that in a pre-contrast series. Well, here we are missing that, okay? So that's what contrast resolution refers to. Now, this is just a very simple basic statement. You cannot optimize fully the contrast and the spatial resolution in one single image. These are different attributes to an image, and you cannot get them both perfectly optimized in the exact same image. So that on its own is a problem, but it's got a very simple solution. What do? Well, you do multiple ones, okay? So you will do one acquisition, so you scan the patient once, and you are gonna process that data into multiple filters. Now, this is not different to photographic filters. I'm sure if you've used, I don't know, Instagram or any of these applications, or you take a photo, you can play with them. You will have seen these photos of people that smooth, for example, the face in the photos. And basically what they are doing is exactly what we are doing. Here we are removing noise. What people are doing maybe are removing wrinkles or anything that is, that are seen for whatever reason as imperfections, all right? So it is exactly the same thing, but here we are just altering the sharpness of the image to kind of remove that, or it to go the other direction, instead of smoothing things out, to make sharper margins. So we generally call them either sharp or high frequency. And this is what we will be using to look at things like that. The tympanic, we can see here beautifully the cochlea of the inner ear. We can see the canaliculi there. And then we have the other extreme, which is soft or blurry or low frequency filters, which is the opposite, which we are going to use to look at the soft tissues. So the idea is quite basic, but you need to understand that for every single body area, you need both. Okay, you cannot see everything in one of them. And we will see that with some examples a bit later. So which filters do you use? Basically, for every time you do a pre-contrast acquisition, which that should be every single time you scan something, even if you give contrast, you always do a pre-contrast series. So in that pre-contrast acquisition, you do at least two. One is going to be sharp, one is going to be soft. It's as simple as that. Every scan, you need two. It doesn't matter if it's an elbow, you still need the soft tissue series. Doesn't matter if it's an abdomen, you still need the bone. Now, if you do give contrast, you obviously are going to need additional series. And this is a little bit different depending on where the contrast is located. Generally, when we talk about post-intravenous contrast, we are looking at vessels, and particularly also at organs or how a mass or a lesion enhances. A good example is this head, for example. We can see the muscle, how it's got very heterogeneous enhancement. So it's got these areas that enhance. We are not looking for sharp or detail here. We just want to see this area being different density to this one, for example. So these are changes that are quite subtle, and you need good soft tissue resolution. That's why generally for post-intravenous contrast series, all we need is a soft tissue series. You can still do the sharp, but generally it's got less clinical value. Now, if the contrast is confined within a space and it's got high density, and a good example of that is a myelogram, but you can think of an arthrogram or the contrast, which, even if it's given intravenously, it finishes in the ureter. That now is a sharply demarcated structure with very high density. It's a little bit like looking at bone. So in these cases, like, dacryocystograms, fistulograms, anything like that, generally speaking, a sharp filter would be preferred. Okay, if in doubt, to do both. Okay, but that's the idea. You always do both, at least for the pre-contrast series. Now, how do you select them? How do you choose them? I think here you are going to really need, if you don't know how to do this or you are unsure, you are going to need the input from a specialist, application specialist. So someone that knows your system, that specific brand, your workstation inside out, and they will help you with this. Because it is extremely confusing. There is totally different ways to do this depending on the system. So for example, Siemens, Toshiba, and Canon, they use a system that is numerical, but also with some letters. These are some random examples. There are hundreds. This is from Siemens scanner. You've got literally hundreds of combinations, but you get a number, and the tens, it tells you how sharp it is. So if it's a 10, it's going to be very soft image. If it's a 80, 90, it's going to be very, very sharp. You get some other numbers, so the units, which have a very specific meaning. It doesn't necessarily address the smoothness. For example, I don't know, B45F. So the 5 after the 4 indicates it's a calcium scoring optimized image. So that goes into an awful lot of optimization, which very often is difficult to keep up. And then there are some letters that may indicate things such as, I don't know, this B is for body. So it's specifically designed for certain body regions. Other times you get something like an I, which indicates an iterative filter. So there's a lot of complexity around it. You will not be selecting them every single time, but when you are setting your protocols, you need to make sure that you've got one that works for soft tissues, one for sharp, for every body area that you are going to scan. And with G, it's much simpler, okay? You just can forget about the graph, but these are the filters, and they've got names, which make things very obvious. It can create a bit of confusion, because then people will see a bone and they think, they start to get confused between the bone filter and a bone window, which we'll explain later. But it is quite straightforward. So soft, the softest, lung, the sharpest, and everything in between, okay? If you have a G, this happened before, I've seen it quite many times. They see something that is called a standard. I say, well, I'm not trying to do anything fancy. I just want standard images. So they think that a standard filter is just going to do everything. But a standard filter is actually a soft filter. If you do a head on a standard or a thorax, you can forget about seeing the teeth or the lungs properly. Okay, so you will still do a standard that will work for the soft tissues, but then add something like a bone, edge, or something like that. So very different depending on the manufacturer. Now, we're going to talk about the windowing. So this is not processing. We are not changing the image itself. We are just changing the way it is displayed. Why this is not very familiar to people is because we are more used to maybe work with radiographs, and in radiographs it's a total different story. You could get a radiograph displayed just using 5 grays. So start with a white, a black, and then 3 in-betweens, because we only have 5 opacities. The system, the radiographs cannot resolve contrast resolution any better than this. So any soft tissue will be identical in the radiograph to any fluid. That's why here we don't see the heart, or we don't see the diaphragmatic outline, because there is some fluid creating that shadow, okay? So it's very easy to display in an image 5 different shades of gray, and for your eye to identify them. So we don't need to do anything fancy. But when it comes to CT, even at the most basic system, generally we work with 12 bits pixel depth, and that means the machine is measuring up to 4,090 different attenuation values. If you use something like an extended scale, so there are different ways to scan, this can go up to 50,000 attenuation values. So it's a massive scale. This is no longer 5 values, now it's over 4,000. And if you imagine an image, this is the tiny little image I've just made randomly. We've got a grid of pixels. Now the system is able to tell us the value of each one within that scale. So, okay, this pixel is worth this one is worth this. Obviously, if you look at an image of pixels and all you get is numbers inside, your eye is not going to recognize the anatomy. We need to assign them some kind of like a shade of gray to each of those values, basically. So you could tell, okay, if it's minus 96, I don't know, you use this kind of gray. If it's 3,000, you use white, and so on. But here's where the problem comes. If you try to put 4,000 different grays into a screen, you'll realize that your screen cannot display those. Generally, most screens will not display more than 256 or around 500 grays. So now we've got a lot of data that our screen cannot show us, even if we try. But that's not the concern, and don't worry about it. The concern is the human eye, which, despite the fact that it's quite good, apparently compared to certain other animals, other mammals, still really poor. Okay, generally 30 to 50 shades of gray that you can see. You cannot see more than those. With the right conditions, adequate training, like a very good specific type of screen, some people may be able to differentiate into the hundreds, but definitely nowhere near 4,000. And this is why we do this windowing. Okay, even if we've got all of that data, our eye cannot perceive all of the difference. And window, when we call our windowing, is 2 numbers. So it's window width and window level. And all we are doing is telling the machine how many of those values we want displayed on the image and at which point within that scale. And what that is doing is altering the contrast, so giving us a more black and white or more kind of gray fading image, and center at different points along the scale. And I'll show some examples, and it will make sense. Okay. Now, this is not a precise pair of numbers. I see sometimes people taking notes. Okay, so for brain we do 150, and for whatever. It doesn't work that way. Any viewing station will give you a starting point. Generally, you will have some buttons or some presets that will tell you, I don't know, brain, mediastinum, soft tissue, bone, whatever window it is. And you can use that as a starting point. You select that, it will give you an okay image to look at that specific anatomy. But from that point, you need to start to adjust it. And you adjust it based on many factors. Like, for example, when I start in the mornings, my eyes are not adapted to the screen, I would use different settings. If I open the window and there's more light, I will change them. If I change from one screen to another also. So there's lots of little factors that will mean you do tiny little adjustments. So do not worry about the specific pairs of numbers, because if you start to worry, just to let you know, there are somewhere around 30 billion of them when you work with a 12-bit screen. If you work with a 12-bit depth. If you do something like extended scale, it's probably in the trillions. Okay, so it's not something that you need to memorize. But you don't need to, and this is the idea. So this is a line where we can plot all of the values that the machine can measure. And the way it works is quite simple. So you would scan a bit of water and you will measure its density. And once you know that, you're going to assign in that scale a value of 0. Water is 0. And then for air, you do minus 1024. And then you can scan, and everything else will fall somewhere along that line. That's basically what is happening. Negative is going to be the only things that are negative density is air and fat. Everything else is more dense than water. So you can think that animals being mostly made out of water, a lot of things are going to be just a bit more dense than water, but very close to it in density in this area here. And then in the other extreme, you would have things like bone, which is going to be very, very dense. Okay. So that's the idea. Now, if you want to make this into an image that you can see all of those numbers, you could do something like this, and then you tell the machine, okay, anything that is less than this value, make it black. Anything more than that, you make it white, and everything in between, just apply like this linear gray scale. And if you look at what this would look like, it's going to be a very flat image. There is very poor contrast, but it's an excellent image, for example, to look at bone. This is what you would do as a bone window. We see the bone beautifully, but look at the lung. You cannot see it at the same time as the bones in detail. And if you look, for example, at the liver, we know there are blood vessels there. We cannot differentiate them. We know the liver is got a different density, for example, than this muscle or than the aortic blood there. And everything looks the same because basically from water to whatever it is here, they are too close in that scale of grays. So if you wanted to, for example, see the lungs, you need a lot more contrast. You just want the machine to tell everything, that is close to water density, make it white. Everything, doesn't matter if it's urine or cortical bone, make it white. Everything that is pure air, make it black. And that's going to give us a very black and white image, but that allows us to see beautifully the pulmonary vessels. But you can see that now we can see the lungs, but we no longer see the bone. And as another example, if we want to see, for example, the blood and the liver as different things, we're going to have to center the window somewhere in between so that liver, for example, will appear as white and blood as a darker gray. So if you do that correctly, now you've got a very narrow window, very contrasty, allows you to see those differences which you cannot see in any of the images. But for example, these two images on the left, they are identical images. These are not different series. It's the same image. We've just changed this kind of contrast and brightness. So I know it's a bit confusing. So we've got filters for one side, which are the series that you get out of the scanner. And then which each of those you can apply hundreds or thousands or millions of windows to each of the images, but are different things. Another thing I wanted to touch base is display field of view. I think this is quite obvious if you've ever run a CT scanner. It's the same as in photography. So let's say we've got this image, which is 4 megapixels, which would mean there is a grid of pixels that is 2000 by 2000. And I take a photo of this in my garden and I said, I want to see that specific little flower. So I'm going to zoom on it. And basically all I've done is take, for example, here like 100 by 100 pixels and make them bigger. What happens that then what you start to see is the pixels themselves. I don't know if this shows nicely on your screen, but you can see all the tiny little squares in this image. And the resolution is very poor because now we've got 0.01 megapixels. If you wanted to see that photo in detail, what would you do? I think it's quite obvious. You either use a very good optical zoom or you just walk to the flower and take that photo. So now we've got the same full 4 megapixels, but applied to a tiny little area of that image. And this is fairly similar to what CT does. The CT is going to scan anything that goes inside it. It's going to collect data for every area inside that gantry. The thing is, it needs to process whatever areas you want specifically. So if you reprocess the whole gantry, here we're scanning elbows, but we've got like a massive field of view. This image is 500 by 500, for example. If you zoom into that elbow, this is what it looks like. You start to see the pixels, and now you don't know, is this a fissure or is that an actual black pixel? What is that? You see all of the square kind of step things. And this is a shame because people, think of elbows high resolution and they do super thin slices, 0.5 millimeters with massive overlap. And then they do something like this with a massive field of view. It's totally pointless, okay? Because what you are gonna gain in resolution because of the thin slices is completely wasted because of the field of view. If you use as the machine to actually go back to the raw data, find the data that belongs to that specific area and process it with the same big matrix, now you've got a beautifully smooth image. And we can see that that's just a little bit of trabecular bone that extends there, which is completely normal, okay? And this lack of resolution, it extends into the MPRs. It's the same dog with different field of view. And, if you try to look at congruity, I don't know, because I don't even see the joint space, like the humerus is fused to the radius here. If you repeat that and do things properly, all of a sudden you can see the joint spaces beautifully, okay? So yeah, it's not much point in using submillimetric slices if then you use a massive field of view. The field of view should include only the anatomical area that you are interested. And this another example happens often with the spines. In this machine, the field of view is rectangular, sorry, square, and in this one is round. Each brand do their own thing. But the idea is the same. If you're doing a spine, you process only the spine. You do not process the whole abdomen, other than this is gonna, and costing more, because now as a radiologist, I need to look at the spine, and then when I'm done, I need to look at the entire abdomen. That takes me twice as long as to look at spine. Basically, you are also ending with a poor image quality. The image quality, it's not going to be, the diagnostic value is not going to be the same. You start to look at the small stuff, it makes a visible difference. The joint space, for example, here you see it beautifully, while here you don't know if it's narrowed or what's going on. And that's just loss of a spatial resolution because the field of view. So now with those very basic concepts, we can look at, how do you do, for example, a basic head CT protocol. First of all, let's say we're doing pre and post contrast. That means your machine is going to run twice, but you're not going to finish with 2 images. In this case, at least we will need 3. So the pre-contrast, you do your sharp filter, that will be series 1, soft filter, series 2, repeat the scan, and do the same thing with the post-contrast. But here we are really focusing onto the soft tissue filter. And it's very important that when you do this, you do not replan this, don't change any values. You just copy paste the exact same acquisition parameters and the exact same processing parameters. The goal is to make series 2 and series 3 identical, exactly the same image, except for the presence of contrast. Okay, so you shouldn't really be changing any of the parameters. And this is everything that is needed. If you get those 3 right, we just need those 3 series. And now when it comes to viewing, we can do anything we want. You can do the MPRs. You can review, for example, the bone series, all of the areas that are of interest. And then when it comes to the soft tissues, we can compare pre and post contrast. If you look here, we've got quite a good image. We can see the white matter really nicely. And when it comes to the post contrast, for example, we see beautifully the normal leptomeningeal enhancement. We can see the falx, the main arteries of the brain, and so on. So that would be kind of a very basic protocol when you do pre and post contrast. For example, for a CT, it's exactly the same. Do a sharp filter, do a soft filter. There is no need to do a lung filter or a bone filter, because it's not really, what is a lung filter, what's a bone filter. They are both sharp filters. Generally, for lung, we tend to prefer a bit sharper filters, but this is more of a personal preference. There is no really clinical impact on that assessment, whether you do one or the other. You need something that is sharp, and you can see here the exact same image is going to show us the bone really nicely. It's going to show us the lung also very nicely. And then the soft tissue series for the pre-contrast and the post-contrast, which should match and give us like good soft tissue resolution. And this is the same, for example, for abdomen. Now, if your protocols get a bit more complex, so let's say you are doing a 2-phase study, you will be adding obviously more series. So this abdominal protocol, we've got pre-contrast, we've got a bone and a soft tissue. Now we've done an arterial phase, and we are going to process it with a soft tissue filter matching that. And now we do, for example, let's say a portal phase, and now you could add another one and so on. So generally for this post-intravenous contrast series, we just do the soft filters, okay? And they are all necessary generally. Like, here you want to see that calcification in the kidney. I know in the abdomen, some people don't do the bones, but we've got a spine. We may as well look at it as well as we can. And also things such as tiny, small bubbles. I've got really good examples of small bubbles free inside the abdomen that are not visible in the soft tissue image because they are blurred out. Or small ureteric stones and things like that. So definitely always make sure you do both. And then for the subsequent series, just do the others. Now for orthopedics, so let's say, generally for elbow dysplasia as an example, we do not give contrast. So it would be simple to think, okay, well, then we need just 2 series, like a soft tissue and a bone series. Yes and no. And I'm going to explain why. So first of all, you do your acquisition, and now we're going to do the soft tissue filter, the soft tissue series. And in this case, we don't really care much about spatial resolution. So we can use a big field of view. And that's actually going to help us smooth out a bit the image as well, get rid of a bit of the noise, because we are making those pixels a little bit bigger. So this would be perfectly reasonable and acceptable as a soft tissue filter. But when it comes to orthopedics and to looking at bone, you really need to have a small field of views. So here you would go back to the scanner and you will tell him, actually, I want you to reconstruct only this elbow and do so with a bone filter. And this is what you would get. You would get series 2, which is the right elbow. And now, for example, you would do the same thing on that elbow and you would get the left elbow with the exact same resolution. Okay. If you were to do in a relatively big field of view, anything over, I would say 12 to 15 centimeters, both elbows, the resolution starts to drop visibly. Okay, so that's what you should be looking at, for example, in this particular case. If you can keep them very close together, let's say the stifles, for example, you put them one against the other, you will probably be okay just by reconstruct them both together in the same field of view. And after going through that, I'm just checking time. So we've got about 10 minutes for this, 15 minutes. I wanted to explain you briefly how to do a quick image quality check. If you are reviewing images or if you are acquiring images and you want to check quickly whether your study that you've acquired or that you're going to look at is good quality, that you are going to get as much information as you can out of it, I think it's critical that you know how to do that. And I would encourage anyone that looks at any imaging modality to make this your very first step. First, to check if the images are good before you start to look at them into detail. And with CT, there are 3 very simple steps. One, you check you've got all the required series. Second step, you are going to check spatial resolution in a sharp series. And the last one, you're going to check contrast resolution in a soft series. And I'm going to explain how to do this in detail, but if you do it systematically and you do it often, we are talking about few seconds to do this. It's immediate. As soon as you open it, you're straight away, okay, I've got all the series I need, and yeah, the images are good, okay? But it's good. I'm going to give you some references, some tips as to how to, as objective as you can, make that decision that image is good quality. So do you have the required series? First of all, if you are familiar with your system, you will know what the series are labeled. But be careful, because the series name, this is something that you input in the machine. This is called head brain, but probably I could have put whichever name I want. So this does not always necessarily match the filter. Okay, so if the protocols are properly set up and the person running the scanner is meticulous, it will work, but not always. So if in doubt, just do a quick visual check. And it is very simple. What I do is I open all of the images that I have. So in this case, we've got a head. I've opened the 3 series. And now I have put exactly the same window to each of those series. And this is a brain window. So we are looking at soft tissues. So which images good look, which ones look bad? I think it's straight away. I don't know if you notice, this one is grainy. It's absolutely horrible. So this is telling you, this is not a good image for the soft tissues, because this is a bone filter. So it's pretty, that doesn't get along with this filter. These ones here look very good. We can see the brain as darker than the muscle, and probably, I don't know if it will show on your screen, but we see quite nicely the white matter as well. So it's a good image. So it's a soft tissue image. And the difference with this one is that this is pre and this is post, because we can see the contrast here. We can see it in the vessels. Now it's pretty clear. We've got pre and post contrast of tissue, great. And then we've got the bone series, which is great. So we've got a complete study. And I could have done the same thing with another window. So exactly the same 3 images, but now I've put a bone window. And if you look at them straight away, you can see this one. The bones look beautiful, sharp. Look at the TMJs. I mean, everything shows really nicely. And these ones look blurry. If you look at images like this for very long, you get actual motion sickness, because these are soft tissue series. So they are not designed to work along this window, okay? So you can see it's very quick to identify which filters you have without having to read through the metadata or try to trust the series name. So you do that, okay, I've got all of the series. So now you take the one that is the sharp series, that bone filter or lung filter or whatever it is, and you're just gonna zoom into either a bone or into the lung, the periphery of the lung or something like that. And just look at it. It's the same 3 images we discussed before. These are 3 excellent places to look at it. For example, in a coronoid or an elbow, you will look at the detail of how you see the subchondral bone, how you see the trabecular bone, and so on. In the nose, I think, in the head, the nose is an excellent place to see that you see all the turbine as well, that you see the teeth would be another one. And also that you can see the lung vessels sharply and all the way to the periphery of the lung. Now, here we're looking at the spatial resolution within each of the transverse images, the primary plane of image acquisition. But remember, there's 3-dimensional information here. So we also need to check very quickly that the resolution, the spatial resolution, is good across the planes. So we generally do that by doing a sagittal or a dorsal. So just by reconstructing the image in any of the plane, which any software that you use should be able to do. And make sure, that this humerus looks rounded, that we can see nicely the joint space and so on. Or here, for example, that you can follow the skull and it looks quite a sharp line. There's no steps or anything. And this is just what happens if, for example, these images on both in the transverse plane are identical images. The only difference is that these ones are consecutive images. So it starts to look like a ladder, like steps. While in this one, the images overlap a lot, and that allows us to make a better image, okay? So just make sure to quickly check that as well. particularly if it's like orthopedics, where we are likely to need MPRs for interpretation. That's just another example of how two images that in the transverse plane are identical, they look completely different, because in this one there is more overlap. Okay, so here we can see the periodontal space is still not the best image, but quite a good image for teeth, and this is pretty much of no use. So if you find out that your spatial resolution is bad, you are doing something not well at all, and it should be fairly simple to know what the issue is, because spatial resolution, the CT does well without even trying. If it doesn't look sharp, make sure you are looking at the correct filter with the correct window, first of all. If it doesn't look good, check that the field of view, that you haven't reconstructed a huge area that is just focusing onto that specific area, that the slice thickness is correct and the patient is properly positioned. So this is unfortunately some of the elbows that we get to read, and you start to see black areas here. Is that a fragment, or I don't know, because you know could be a fissure, but see, there's like another fissure here that crosses from one bone to the other, so that's not a fissure. And you start to see these fissures going from the bone into the soft tissues, you know, so those are all artifacts, not only because of the field of view, which is this, so you can see they've reconstructed a massive image, so this is never going to look, it is going to be impossible to get a diagnostic image of that elbow, but also, you know, there are other factors that are positional, okay? And yeah, just check quickly that the resolution on the MPR is good. So this is the same study. This is on the transverse plane, looks great. On the dorsal, looks horrible. All these steps, you know. And basically that is just a little bit different. The cause is that your images are too thick, or there's not enough overlap amongst them. Now, for contrast resolution, it's a little bit trickier, but it's not difficult. Find, first of all, a soft tissue series, the soft tissue filter or kernel, whatever you want to call it, and use a very narrow window. I go for brain windows always. I think they work fantastic. So once you do that, what should you be able to see? First of all, the image should be relatively smooth. Now, some graininess is always going to be there. It's a feature of the image. Don't expect it to be perfectly smooth. But you should be able to use a very narrow window and still see densities in an image that is okay, that is not painful to look at. Now, you should be able to see specific differences in attenuation of different structures. And for each body area, I think there is somewhere where you can benchmark, you know, just check your quality. Is this good or bad? Head, for example, is a great example. For the teeth and the bulle and whatever, I know you're going to do a great job. But this is where you want to get regarding soft tissues. Take that soft tissue series, look at it in a brain window, and you should get an image that is still smooth, starts to look grainy, but you can see, for example, the gray and white matter differentiation. To me, that's a hallmark of ideal quality. Okay, that's what you are trying to achieve. For the thorax and abdomen, there are, well, this one on the bottom right, you can get them in both because the liver is included in the thorax and in the abdomen scans. In the thorax, you also have the heart. But the idea is to identify the fact that the myocardium or the liver are more dense than, for example, the vessels. So you should be able to see separately the heart contents from its myocardium, and the same thing, you should be able to identify these vessels inside the liver, provided, obviously, everything is normal, like the liver is normal, the blood's got normal density, and so on, which generally it is. Okay, if not, you can always use the same window and try to look at something else. You can see the same thing on the spleen, for example, or different areas. So this would be what I would use for thorax and abdomen. If you can see that, great. And if you're not sure, open one of the studies that you are doing or you're acquiring or interpreting and take a look. Okay, but that's what you would hope to see to some extent. For the limbs, we just try to do an image that is relatively smooth. And if it's good, you will start to see things. It's not so critical as, for example, for the head, but you can see the lymph nodes, for example, are less dense than muscle generally. Or this dog has got a bit of effusion, and we can see the actual fluid in the joint is less dense, for example, than the joint capsule, or that the tendons here in the triceps or in the extensors are a bit more dense than the muscle, and so on. Okay. For the spine, it's quite tricky, and I will challenge you to do this. And if you manage, is that your study is very good, and it's going to make the interpretation very easy. You start with a brain window. If you do a brain window in a spine and you can see the spinal cord well, you've got an excellent study. It's as simple as that. If it just looks all grainy and horrible, you are going to need to decrease the noise somehow. But just try to change the window gradually until you can appreciate that the cord is less dense than the muscle. And if you manage to do that, if you hold that window and scan through the spine, I guarantee you that the smallest hemorrhage, even cavitated lesions, even, you know, you will start to see a syringohydromyelia as you start to get a lot of information out of the study. But this generally requires a massive amount of radiation. Okay. If the contrast resolution is poor, just check you are looking at the actual soft tissue filter, not the bone filter, because obviously it will look absolutely horrible. And if it's still not good, you can try to make thicker slices. Thicker recons will give you better contrast resolution to a certain extent. Obviously, you cannot do 1 centimeter slices because then you lose too much of the spatial resolution. Okay, and if it's still noisy, then you just need more photons. You need higher MA, a longer scan, decrease the pitch, or do something to make sure there is more radiation going through the patient. Now, remember, noise is a feature of any image. It's always going to be there to a certain extent. And the more you irradiate the patient, the less noise and the better soft tissue resolution. But you have to be reasonable with the use of ionizing radiation, even if it's less of a, it's not as much of a concern when you scan people as when you scan animals, because we do not care, but it's just down to the way radiation interacts with biologic, with matter, basically, and the lifespan of the patients. So there are significant difference in the consideration with this. And it's also maybe not a very good way to compare, because generally what they are looking for on a CT in humans differs a lot from what we look in veterinary. Okay, I mean, how often you're going to be using CT used as an investigation of epilepsy in humans, and it's going to go for MRI. But sometimes in animals it's not the option. So we need to maximize and try to retrieve data, which potentially in humans they would just do differently. Okay, so radiation, remember, you still have to be conscious. You are still radiating a patient. You are also increasing the use of your system. So you have to be reasonable. And it's always like finding that balance in between very good image quality and abusing the use of radiation. So just remember those 3 steps. I put them there. It's very simple. Check you have the series. Open the bone series, you check the spatial resolution. Open the soft tissue series, you check the contrast resolution. Okay, so the idea is relatively simple, but I think particularly if you, let's say you've only worked with 1 scanner or you are relatively new, it's very common that you kind of get used to certain images and you kind of accept them as, well, this is what CTs look like. So sometimes it's good to kind of benchmark the image quality against other systems, or just try to take those ideas that, you do a head. Can you see properly the brain, or can you see in the abdomen in the pre-contrast series the hepatic vessels as being less dense than the liver and things like that? Okay, so that will allow you to kind of set up a standard and make sure your images are correct. So we are gonna leave it there. I'm gonna run a very quick poll for those that were here. It's the same. So it's just to get a little bit of feedback, if you don't mind answering those 2 questions. It's just to get us a little bit of feedback so we can work in future presentations. And whenever you are done with that, if you have any questions, I'm happy to answer them. I don't know how we are doing. We have 10 minutes, so we are good time-wise. So you don't hesitate to ask anything. You can put it directly on the Q&A there. I'm gonna stop sharing my computer. All right, and I'm gonna open the Q&A. So yeah, you can answer that, and I'll check quickly the chat in case someone has asked something there. Yeah. Okay, so I think we'll cut out 60%. Okay, perfect. If you cannot think of anything right now, and at a later stage you work on any suggestions for further webinars, you can always email us. Adele is asking a question. So do you usually recommend contrast when looking at sinuses? There's been, every time we do these kind of presentations, it is very often people are very interested in contrast. So either very specific questions like this one, or about, how much do you delay, when, how do you give the bolus, how many series you do for this or that. So I think that may potentially be a topic for we can do a half an hour or 1 hour webinar, because it's quite a broad topic. Do I use it for sinuses? Adele, it really depends. Now, when I'm running the scans myself, or I'm in the hospital where they're being done, I normally review them immediately there and then. If I am particularly just focusing on the nose and the sinuses and they look normal, I would not give contrast. If you are not doing the interpretation there and then, and you want to make sure you've got everything, then do it. Okay, don't hesitate, because if not, you may have to, you may suddenly decide, actually, we should have done contrast, now we need to get the patient back in and so on. But if they are normal, it's not going to tell you anything. However, if there is pathology, whether it is fluid, let's say, you've got the sinus full of something, that is not air, you will want to give contrast because you need to know whether that's a solid mass, whether that is just fluid, or if it's just fluid, there may be a reason why the sinus is blocked or things like that. Or maybe, if there is lysis around the sinus, you may want to check the brain in a lot of detail. So yeah, it really depends. If it's normal, not necessarily. If it is not normal, or I am sure, I'm not sure, then I would definitely do the post contrast. Barbara has got another question, and Adele or anyone else, when I answer the questions, if I don't answer your question, you've got more questions, just ping another one and I'll go through it. So Barbara, would you recommend open mouth head CT and then another series of closed mouth? It's a very good question, and it really depends what you are looking at. Generally speaking, I would always scan heads with the mouth slightly open. You don't need to kind of crack it open all the way, but just put something like a syringe or something like that. The reason for that is because that way we, when you open the mouth, and also I forgot to say, once you open it and also pull the tongue, what we do is we fill up, we increase the volume of the oropharynx and let the palate have, go a little bit ventral and show the nasopharynx better. Also the pharynx, we will see it better. Obviously, there's an ET tube, it's not so important, but generally we would open it a little bit. And there are circumstances where I would do neutral, potentially a fully open, and that means, putting a gag or something to open it as much as you can, and then repeating it close. And that is when you've got, if you've got a specific concern about the TMJs. So dogs with open jaw locking that we sometimes see, or the dog has got pain when chewing, or is head shy and you don't know where the pain is, there may be need for that. So it's when we want to assess basically the range of motion of the TMJs. In those cases, I would do open and close, but it's a relatively rare indication. So most of the time I would not do that. But the opening the mouth is amazing how much it changes when you look at the larynx. So particularly for brachycephalic scans, always open the mouth and pull the tongue. Okay, the larynx of brachycephalic is just very busy, and it's difficult to see the palate, to see everything. So if you do that, you kind of remove the soft tissues a little bit and get a better view of the air distribution inside the larynx. Amy Roth, that's a familiar name. Did I understand correctly? I don't know if it's the same Amy Roth I know. Did I understand correctly in regards to slice thickness effect? If getting a stair stepping on the NPR planes, the slice thickness is too thick or not acquiring helical. No, I think when you look at the NPRs, this is actually quite interesting because we've always looked at it as an issue mostly with the slice thickness. But I've played a lot with the scanners, and sometimes I've done, for example, in a head, a 3 millimeter slice, which is huge, but then reconstructed, for example, every 0.3 millimeters, and the NPRs still look good. So I think in any case, when your NPRs don't look good, the main issue tends to be slice thickness and mostly slice overlap. It doesn't really have anything to do whether it's helical or well, it does in a way. The difference between helical or sequential scanning, which I think we barely ever do any sequential scanning, is that with sequential scanning, for everybody that doesn't know what that is, it means that the scan acquires the slices stationary. So the table is not moving, scans the patient moves, scans again, moves again. If you do that, the slices do not overlap. So basically in sequential scanning, you will always get like the step ladder kind of artifact on the NPRs, because you cannot reconstruct the slices that are one over the other. While in helical, you can reconstruct the slices at any point. So you can reconstruct a slice here, and then the next one is actually part of the same. It kind of has redundant data. So I don't know, maybe I did not explain that particularly well, but whether it's a soft filter or not, it is generally just it is both factors. It's mostly the overlap, but also the thickness. I think it's irrelevant to the soft filter. The only thing is that with the soft filters, you do the NPRs and try to look at it, for example, with a bone window, it will never look very good. It will always look a bit blurry. Okay, so I'm not sure, Amy, if I answered that. But if you are Amy Roth, the radiologist, you can you can send me a message anytime. We can discuss it in more detail. Okay, I think that's it. I think we've got 3 questions. There is time for more if anyone's got them. So I'll give a minute. I'm just checking very quickly the poll. Okay, it's common CT acquisition mistakes and how to avoid them as a suggestion. I will check the webinar chat box. And, at the moment, there is nothing specific there. Okay, so I don't know if there's no more questions, guys. I'm gonna close the webinar now. Thank you very much for your assistance, and we will let you know if there are any more. I'm gonna think of this. I have one more question. I was gonna say we will let you know if based on the feedback we decide to do some more of these webinars with different topics. So Adele has got another question. Can I assess for a liver shunt without a power injector? Yes, you can. Absolutely, you can. Now, this is going back to the contrast administration, like bolus delivery, timing, things like that topic, which I think it may be a very good one to discuss in another webinar. Now, power injectors, I love them. I've worked with and without, and I can tell you that sometimes, even if I like them so much, even if I've got an injector there, sometimes I go and inject by hand because I'm a bit lazy. You know, depending how your injector is, if you need to change the syringe and top it up every single time, it can be a bit of time consuming. So technically, you can do pretty much anything without a power injector. The only thing you will not be able to do is the arterial phase, particularly in big animals. In small animals, you will still be able to. And I'll tell you why. Let's say you inject a dog that is a big dog, I don't know, 40-kilogram dog, and you want to inject 60, 70, 80 mLs of contrast on that dog. If you have to inject that by hand, it doesn't matter how thick the needle is. Well, it doesn't matter. Maybe there's someone out there that manages. But even if you inject directly into a massive catheter with a big syringe, you are going to have to change syringes. It takes time because the contrast is quite dense. So basically, the arterial phase will very often start before you are finished with injection. That means that if you wanted to do that, you would have to be in the room irradiating yourself while you acquired, which is something that it should never be done, really. So if it's a small dog or a cat or something, you need to inject, let's say, 10 milliliters. If you've got a decent sized catheter, you can inject very quick and get out of the room and start the scan. Okay, so you could do it. The only problem is that to get a very good arterial phase, what we do ideally is that we fire with a power injector at the same time as we are scanning statically. So basically the scanner is running without moving and is reading those images live. And as soon as it detects the bolus of contrast, then it fires. Okay, so timing arterial phases is very easy if you've got the power injector. If you don't have it, you will make mistakes. But answering your specific questions, liver shunt without a power injector, my answer would be 99% of them you definitely can, because the phase that you really need is a portal phase, which it rarely starts before 30 seconds. So it's fairly easy to just inject that, have a walk out, and then acquire the images. And every time I should specify that when I mention timings, it is from the moment you start the injection. So I said 30 seconds, you start to count when the contrast starts to go in. Okay, so for liver shunts, generally, in my opinion, this is a very controversial opinion, arterial phases are not rewarding at all. Now, there are the few cases where it's not rewarding, it's just that it's critical. So arteriovenous fistulae, for example, if you've got any kind of arteriovenous malformation, then you do need the arterial phase, okay? But for the 99.9% of cases, which is just a portosystemic communication, the arterial phase, it tends not to be very rewarding, okay? So yeah, I think this gives me lots of ideas as to discuss. I think we could do a whole presentation on contrast, could be very, very useful, because yeah, seems to be people have a lot of questions, and the reason for that, amongst others, is not just that it's a complex topic, is that there is very little agreement amongst specialists in the literature. Like, you will find protocols that are totally different. Some people use a massively tight bolus, so they inject very, very fast, and they push that with saline, with a second, like a chaser. You've got these dual head injectors, while other people do the opposite. They inject very, very slowly, and that allows them to, for example, get an arterial, portal, and venous phase in one single image, because the contrast is a little bit everywhere. So you get a bit less density contrast, but a bit better distributed. So there are very different schools of thought here, but it still is something that may be worth discussing. Okay, I think that was, there's no more questions coming. Yeah, cool. Okay, so I think we're mentioning. Okay, right. Yeah, so it's going to be a recording that will be emailed to all of you. Yeah, and if you've got any questions you can think of, you can always email us. Okay, so yeah, I'm going to cut here. Thank you very much, everyone. It was great having so many of you here. And again, I hope you enjoyed it, or you learned something, something that was potentially of use to you.